and I'm going to really focus on picking up really where Mitch left off and talking about MRI and trying to really, I like the slide, who was it showing earlier, how, the adoption, the rejection of technology, oh, that's right, Jason, about proton beam, kind of the rejection of technology and the wholesale, fervor and adoption of it, then the rejection again, and then finally some midpoint. So I think in terms of MRI, we were complete rejection until about 3 years ago. Now it's the greatest thing since sliced bread, a little bit too much the other way. I think eventually we'll get to where we need to be. So I'll try and show some of the data. We've been working on this for a very long time, and then really try and talk about some of the newer ideas really to improve imaging of early stage or newly diagnosed prostate cancer. I showed this slide before about the challenges for imaging. I'm going to really focus for this talk about initial evaluation of the prostate at the time of diagnosis. So multiparametric MRI, you heard the brief introduction. It can be used for many purposes, has many roles, and they're expanding. We initially got into this in 2002 and 3 because we were starting to do robotic prostatectomy and you couldn't feel, that was the concern. So the obvious question is maybe if you could see, you could actually replace the need to feel. And so that's how we started it. In 2009, one of my new colleagues, Lenny Marks, came and he started adopting MRI for actually diagnosis and biopsy. And we've also been using it heavily for many, many years to make treatment decisions about active surveillance versus therapy, as Mitch talked about. So I'll try and really focus on just the use of MRI for diagnosis and really try and talk about its sensitivity and specificity, really talk about its advantages, but really highlight the pitfalls because I think they're not being recognized. And I think they're very important. So multiparametric MRI, as Mitch said, it is the key part of the name is multiparametric. So it's not simply an anatomic image with T2 weighted imaging that we're used to seeing, but rather you get anatomic and functional information by getting dynamic contrast, but particularly diffusion weighted imaging, which really measures the ability of water to diffuse through tissue, and has been shown by us and many others to really correlate very strongly with Gleason score. Spectroscopy, initially done at UCSF, has kind of fallen by the way because of issues of cost, time, insurance coverage, et cetera, but I think it does still have a future, and there's a lot of work in this area still. The important thing to know about MRI is it requires really a great deal of expertise by the radiologists to read these. They're really not simple radiographs to read, and they need to be scored in a really kind of an organized way. And the scoring system that's been developed by kind of an international group of radiologists has continued to evolve. We now have PIRADS2, but basically this is the scoring system that is now accepted to report so that you get structured reporting of MRI scores. And the salient feature is that 1 and 2 is really low suspicion, 5 is very high suspicion, 4 is moderately high suspicion, and 3 is really 50-50, and that's actually what the data shows. And what this is a composite of essentially all of the different parameters. If all 3 parameters are abnormal, that's generally called a 5. If 2 out of 3 are abnormal, that's a 4. If 1 parameter is abnormal, that's a 3, and if none or very mildly suspicious, that's a 1 or a 2. So that's the important thing to know as we go through this. So I'll start with diagnosis, and really over the last 6 years, there's been a start to a revolution in the way that prostate cancer is diagnosed. For eons, we've been doing this by transrectal ultrasound biopsy, which is essentially a blind procedure. We see where the prostate is, but we're not actually targeting anything specifically or rarely doing so. And so the idea now is you take the MRI, you could actually do the biopsy in bore in the MRI machine, or you can superimpose the MRI on the ultrasound image and then target any suspicious areas in that manner. And so this is one of a number of different machines that's been developed. We have a couple. Dr. Pantuk, who's here, uses one called Euronav. Dr. Marks has been a partisan of the Artemis device, and they each have some advantages and disadvantages in terms of ease of use and some other features. But by and large, they do the same thing, which is that they essentially take two images and attempt to fuse and co-register them so that a urologist in the office can do this biopsy without having to really spend a lot of time on a magnet in a somewhat uncomfortable position and have it done in the magnet. But there are certainly people who do it in the magnet, and at UCLA, radiologists are doing it in the magnet. We're doing it in the office, and that's it's an interesting thing that's going on. I'll just leave it at that. Anyways, so what does it look like? So two pictures. So this is a man, very typical of what we saw in the way that we started doing this years ago, who had multiple biopsies that were normal, but a rising PSA, highly suspicious. So we did an MRI. And what we see is that as many as 20 to 30% of patients we see have anterior lesions away really from where the traditional biopsy goes. It's located up here. Here it is very prominently on diffusion weighted imaging. Here it is on perfusion imaging. And essentially here's the ultrasound image. The two are fused together. And then you can see that the biopsies are taken through the target. Importantly, at UCLA, we have and we continue to do traditional 12-core biopsies in addition, which we call mapping biopsies because we really map and plan exactly where they go. So we are sampling the entire prostate in addition to the target. And then on every single patient for the past 8 or 9 years, we've done whole mounts of their prostatectomies when they've undergone surgery so that we can correlate the actual lesions found at the time of radical prostatectomy with what is found on the MRI. And that's really where a huge amount of wealth of information comes from. And many people talk about 100% sensitivity of MRI for detecting prostate cancer. They're basing that on biopsy alone without any ground truth, which is the ultimate prostatectomy specimen. So there's a big problem in terms of the way people talk about this and somewhat incompletely. So this is yet another case showing another lesion here on the left side. Again, underwent a targeted biopsy. And in these cases, there's very good concordance between what's found on the MRI and what's found at the time of radical prostatectomy. So I'm going to show a few features of data. So this is a publication. This has been submitted, but it's been presented already by Dr. Marks at UCLA and his team. And this is really the first 1,000 of these biopsies that have been done at UCLA since 2009. And this is really the composition of the group. So this is kind of all comers. There are many patients who had prior negative biopsies. Most are now coming for their first biopsy. As in the UK, patients are getting an MRI first when they have suspicious rise in PSA and then getting a biopsy to a target if they have a target. So this is the entire group of patients that have been imaged and their characteristics. I think the important results from our studies at UCLA have been the following. Number one is that targeted biopsy reduces the diagnosis of Gleason 6, or what we call clinically insignificant tumors. And we could have a debate about what clinically significant is versus clinically insignificant. After 20 years of doing this, I still don't know what that means, but clinically significant is kind of accepted to be Gleason 7 or higher. Gleason 6 is generally clinically insignificant, although high volume Gleason 6, of course, we don't know. But for the sake of this study, Gleason 7 or higher was considered to be significant, Gleason 6 not. So what you can see is there's a reduction. All patients underwent mapping or systematic biopsy as well as targeted biopsy. There's a reduction in the number of patients diagnosed with Gleason 6 cancer, but you can see there's a significant increase in the proportion of patients diagnosed with either a Gleason 7 intermediate risk cancer and even with high risk cancer as well. And we know that conventional mapping biopsy over-detects low-grade cancer and under-detects cancer, high-grade cancer, which has been the problem of active surveillance protocols historically. And if you look at the two together, then the question is, do you need to do a mapping biopsy if you're doing a targeted biopsy? And at least in our hands, and this has been consistent through the 6 years of the program, there does seem to still be a need for doing mapping biopsies because not all high-risk cancers are identified by targeted biopsy alone, and not all Gleason 7 cancers are identified that way as well. So the combination of both techniques, we believe strongly, is still necessary. And this is important because radiologists doing these biopsies in VOR are generally speaking taking one core, and that's it, from a target and not sampling anything else. And I can tell you from a lot of data that they're missing at least 20% of high-risk cancers by doing so. And so this is looking at the PIRAD score in relationship to the likelihood of significant or insignificant cancers. And obviously, the higher the PIRAD score, the more likely the person has cancer than a lower PIRAD score. So grade 3 lesions are only about overall about 40 to 50% sensitive for specific for detecting cancers. So there's still a high false positive rate with PIRAD 3 lesions, but PIRAD 5 lesions virtually always indicate cancer and virtually always high risk cancer. So if you look at the Gleason score based and correlate it with the PIRAD score, for instance, for grade 5, so for PIRAD score 5s, 58% of those had a Gleason grade of 4+3 disease or higher, whereas if you had a grade 3 lesion, only 8% of those were ultimately found to be Gleason 8 or higher, 7 or higher. So this confirms what we already knew, which is that the MRI provides not only targeting information, anatomical information, but also significant amount of functional information. So when I see a person who's got a PIRAD 5 lesion, even if they had a targeted biopsy that showed low-risk cancer, I believe in those cases, I actually believe the MRI more than I believe the targeted biopsy, which of course is still sampling only little bits of a tumor and can certainly miss high-grade tumors. And we know that even a targeted biopsy still, although it does far better than our traditional biopsy, still undergrades about 20% of these cancers and very commonly misses tertiary grade 5 cancers, which are also seen. So what happens, so that's a quick summary of biopsy. How about looking at the actual sensitivity of MRI for detecting what's going on in the prostate? So this is a paper that Jesse Lee, one of our residents, published with the entire group last year. And this is, I think, in one slide, this picture does tell 1,000 words, which is really what is the sensitivity when you actually compare the MRI. Many of these patients do not have targeted biopsies, just comparing MRI to radical prostatectomy, because every single person that I have operated on since 2004 has had an MRI prior to surgery. So we have a large database essentially of all patients who have had radical prostatectomies. And basically what you find is that the larger the lesion is, the more sensitive MRI is for detecting cancer. The smaller the lesion, particularly less than 1 centimeter, the less sensitive MRI is for detecting cancer. The higher the Gleason score in general, the higher likelihood of finding cancer. But Gleason 6 tumors in particular are not conspicuous on most MRIs. And this is the reason that MRI by itself may be a very good selection tool for deciding whether a patient is a good candidate for active surveillance, since most Gleason 6 tumors, at least in our hands, over 10 years have not been detectable unless they're quite large. An interesting thing that's not recognized, which was actually the major point of our paper, was that index tumors were defined as the largest tumor or the highest Gleason score, which may or may not be the biologically important cancer. Probably most likely it is in most cases, but certainly not all. But generally speaking, the index tumor is detected by MRI in 80% of cases. But if you look at multifocal tumors, including high-grade multifocal tumors, these are less commonly identified by MRI. In solitary cases, that's shown here. And so the non-index here, and then multifocal versus solitary here. And this just breaks down the data even further, and I'm going to try and get us out so we can have a little break before 5 o'clock, so I'm going to skip over this. The important point is going to come in the next slide, which is how about MRI detecting high-grade cancers? And what we found is that MRI still does not detect all prostate cancers, even high-grade ones, even though the dogma over the last 3 years has been if you have a normal MRI, despite an elevated PSA, you don't need a biopsy. Absolutely not true. We found that as many as 20 to 30% of high-grade cancers in this series of 122 patients that we looked at were not detectable by MRI. And I see this. We have a conference every single week where we review, or every 2 weeks where we review every single MRI together with every radical prostatectomy. And every single week we see high-grade tumors that were completely missed by MRI. And it's not a reader issue. It's the MRI itself. Generally speaking, the tumors that are missed are, as you can imagine, they are smaller than those that are detected. And there are actually histologic subtypes of prostate cancer, like foamy cell prostate cancers, that are very poorly visualized by MRI. The other thing that's really important, so this is a case, for instance, of a lesion that was seen on MRI here, highly suspicious, read as PIRAD4 lesion. His prostate was taken out because he had a suspicious biopsy actually in the same region on the same side, but indeed his cancer is actually located here, not where the MRI was abnormal, and the MRI did not see this lesion whatsoever. And that's not untypical. The other thing that's very common is that MRI oftentimes is very good at locating a tumor, but very poor at actually delineating the actual shape of the tumor. And so this is not untypical, where here's a low diffusion lesion right here. Take out his prostate, his cancer is large and located here. The tumor is actually located, the MRI showed the tumor as being here. You can see there's overlap, so that would be called by our group as concordance, but it's concordance in terms of biopsy target here, biopsy here, but it's not concordance in terms of the actual size of the tumor. And indeed, when you look at, we've actually looked at this, but need to publish this, we actually find overall a 2 to 3-fold difference in size of the actual tumor versus what's seen on MRI. And so nowadays we actually we put the prostates into a mold prior to surgery. A mold is printed for every single case based on the MRI. And then the engineering group that works with Dr. Marks goes ahead and prepares these, and then Jiaoti Wang and the pathology team essentially do the hole mounts so that we can actually do the concordance analysis very well without issues related to the way that the prostate is sectioned. And this is very common to see an MRI lesion like that, but the actual cancer like that. And so this, of course, has significant implications for the new rage in urology, which is focal therapy. And I think it's something that's being missed. So summarizing this part of the talk, MRI provides anatomic and functional imaging of prostate cancer. MRI-guided biopsies with or without ultrasound fusion clearly increase detection of clinically significant tumors and reduce detection of insignificant ones. And I put that in quotations because of all the caveats of what we do and don't know, as we've been talking about all day today. Overall, MRI does detect about 80% of index cancers, and I think that's really good. So I don't want to, I certainly don't want to talk down MRI. I'm trying to simply give a perspective of its advantages and still the fact that it needs to be perfected further. But can miss about 20 to 30% of high-risk cancers. Generally, they're smaller. Oftentimes, they're not the largest tumor, but multifocal tumors, et cetera. And I think very importantly for the future moving forward, especially for focal therapy, now that HIFU has been approved in the United States, MRI really does not define the shape and extent of cancer very well. It's actually, I'd say it's 50-50 that you'll find an exact concordance between what you see on MRI and what you see at whole mount in terms of the shape. This is particularly true at the edges of the tumor where you may have infiltrating high-grade glands that cannot be visualized. And so if you're planning to do focal therapy based on an MRI image, you will absolutely undertreat a large number of cancers. And so you have to try and find ways to either account for it or recognize or do other mapping biopsies or other strategies if you're going to attempt to do focal therapy, which is another discussion in and of itself. And then also, leading to the next part of the talk, MRI really does not do a good job at detecting seminal vesicle invasion, and it really does, of course, a poor job at detecting metastasis. Other than bone can be detected with diffusion, but not very good for detecting lymph nodes, et cetera. So what's new on the horizon, or actually in practice? Briefly, restriction spectrum imaging, which is an MRI sequence that we've been working on with UC San Diego now for a number of years and have published a few papers. MRI PET, which is starting to emerge. And then, as I talked about a little bit earlier, PET tracer, and I'll just mention what we're doing now, what's available now versus what's coming down the pike. So RSI, I'm not a physicist, so I'm not very good at describing this, but basically current diffusion-weighted imaging suffers from spatial distortion, which limit the ability to co-register the image you get with the anatomy. And so enhanced diffusion techniques have been developed and then optimized and actually are used routinely for glioblastomas and can now be adapted to the prostate. And so we've published a number of papers demonstrating the potential role of RSI imaging at the time of the multiparametric MRI to improve sensitivity. And here's a few cases of lesions that were not detected by conventional multiparametric MRI, but restriction spectrum imaging identified them, and then these were then correlated at the time of whole mount. So quite a few cases. It's also turned out to be better for detecting extracapsular disease than standard multiparametric MRI. Here's another case where lesion not seen or very poorly seen, seen very clearly with RSI, and then confirmed at the time of radical prostatectomy. And so I think we will start to, we're exploring this more in a prospective way, and Dr. Marks's group is using this for doing targeted biopsies. In terms of molecular imaging, obviously the hope is that molecular imaging can not only detect metastatic disease better than conventional imaging, but it can actually detect local disease too. And because PSMA expression, for instance, and many of the analytes, the fatty acid synthesis pathway analytes, do increase and correlate with Gleason score, these also may correlate with the aggressiveness of disease. So here's a case, we do this quite often for high-risk disease. We do C11 acetate PET scans at UCLA for now a number of years. And here's a case with a lesion located that ultimately correlated with what's going on at radical prostatectomy. And this is a patient that I saw actually quite recently. He came to me, had high-risk disease, clearly visualized in his MRI, diffusion, T2 diffusion, and perfusion. But I had a very high suspicion that he could have underlying metastatic disease, so very high risk, and he was a candidate for a protocol that we have ongoing still. And so we had a C11 acetate scan, which showed the lesion very nicely and is in exactly where I showed it to you on the MRI here on the prostate. But he actually had this single lymph node well away from where even an extended lymph node dissection would ever go, essentially pararectally. And this was biopsied and was found to be positive. He still ended up having surgery elsewhere. I actually didn't recommend it. And the lymph node, of course, was not found at the time of surgery because it's away from where we can easily get surgically. But typical case that where we use a C11 acetate scan. So if I have a high suspicion of a high-risk patient, and I think it may actually alter my management, we do C11 acetate scanning quite commonly. I told you about IAB2M and PSMA scans a couple of talks ago, so I'm not going to belabor this other than to show a trial that's ongoing in high-risk patients, which I mentioned, comparing Processint and other standard of care imaging with PSMA scans. And here's a couple of cases, I think. Number one, with PSMA scans, you can also image the lesion in the prostate extremely well. This is bowel, that's background from the zirconium excretion. But you can see here he's got a lymph node here, and then he's got another one over here that were not visualized by standard of care imaging. They're less than 1 centimeter. I think they're about 5 millimeters. These were actually removed at the time of surgery because the protocol involves doing surgery on all patients. They had extended lymph node dissections, and these were both positive. And what's really interesting, in some cases, the actual tumor was 1 millimeter within this larger node, probably related to very high expression of PSMA. And the workup of correlating imaging with the amount of expression of PSMA is ongoing. A few cases that were falsely negative turned out to be PSMA negative as well. So they certainly occur even in early stage disease. This is a different patient. Here you can see his primary lesion. And I think in this case, in this patient, I think that was the only lesion that was seen was the primary tumor, and he did not have metastatic disease. This is, I don't know if this was another or the same patient, another guy with a lesion seen here in a normal lymph node, normal looking lymph node, negative by Processint, and that was positive. And then the summary, I'll just go right to this. Oh, I didn't put the summary slide. Altogether now 6 patients, the first 6 patients have been analyzed. 4 out of 6 had metastatic disease to lymph nodes that were all detected, to my knowledge, with PSMA scans. Although in terms of sensitivity of the PSMA scan for lymph nodes that were found at surgery, it was about 60%. So there were lesions that were too small or were PSMA negative that could not be identified at surgery, or perhaps were not removed at surgery, possibly. And so that's all being analyzed. But at least a high-risk trial that's suggesting and showing at the tissue level sensitivity for detecting disease that historically we would not have been able to detect. So I think this is where we're going for localized and locally advanced disease. And I'll end there. And thank you for staying for even longer.
Thank you, Rob. So a little bit embarrassing. I mean, you know, it's pretty amazing how this has changed. I don't quite know how long you've been in the field, but to imagine what you knew when you were a resident and what you know now, it's, you know, night and day.
See all this gray hair? Too long.
Yeah, no, not too long. Keep
So
at
anyways,
it. Keep at it. You have a lot of work
no,
to
it's
do.
pretty amazing how science moves very quickly, but clinical medicine is actually starting to move much more quickly as well the last 7, 8 years, really.
Yeah.
Thank you. Just a quick question for you. First of all, UCLA has an incredible imaging program. We've sent patients there, even from City of Hope when I was there as well. So congratulations on the imaging program there. It's been excellent. You said one thing about the patient that had the perirectal node.
Mhm.
You said you would not recommend surgery, or you did recommend surgery?
I did not recommend surgery in him because it
Okay.
was found to be positive. It was an area I didn't think we could remove it. I actually had recommended some radiation with stereotactic radiation to the node to him.
Okay. Thanks.
Do I know the answer? Who knows? I mean, certainly we're operating on, as you know, as you discussed this morning, many patients with more advanced disease.
Right.
Whether radiation plus hormonal therapy versus surgery is optimal, you know, none of us know the answer to that.
Hi, Dr. Reiter. Very amazing and comprehensive, you know, comments on all those techniques of imaging. I did learn a lot from it. So my question is, like you mentioned that in even the using the fusion and the MRI delineated the shape of the, you know, the
Tumor.
the tumors as judged by the pathologist, and so you know, you just get a little, I mean, not little, but only part of it. So what do you think that makes that happen? Is that part of more aggressive, you know, considering the whole big size of
So
tumor?
we're looking. So we've looked through these high-risk cases that were missed. Certainly, size is one thing, but certainly in cases where we're underestimating the size, it's oftentimes the shape, it's the intervening normal glands, infiltrating cancer that's not, you know, not a solid tumor. So I think there are many features that essentially are lead to being quote unquote missed with at least conventional multiparametric MRI. I think that, you know, why are some Gleason 7 tumors visualized and others not? I think that there may well be biological, you know, essentially underpinnings of what's visualized and what's not. There's an entire emerging field of radiology pathology or molecular radiology to try and really understand what biologically is being visualized by imaging. And we've been trying to get a program off the ground, if we can find the funding, to really do whole exome and RNA-seq of all the lesions that have been visualized and not visualized. So it's been something I've been trying to get off the ground for a couple of years now, but obviously a very expensive project to do. But I think that will teach us much more about what we're seeing and what we're not seeing. It may well be that Gleason 6 tumors that are visualized very well may be biologically different from the vast majority that are not visualized.
So considering the three-dimensional shape of the tumor area,
yeah.
So I think the MRI also doing the section, so it will not be associated with the density of the tumor at that certain area, right?
Yeah, it certainly may be. I mean, prostate cancers are not nice round tumors like kidney cancers. They come in all shapes and sizes. They're pencils. They're surrounded by normal. There's normal stroma infiltrating, you know, within them, normal glands, and I think that all impacts what's visualized.
Okay, thank you very much.
So the imaging looks great, but do you have an idea like how long it takes for the turnaround for like use or developing these imaging modalities to sort of clinical use at most facilities?
Which ones?
Like the I guess the dye or the bi.
The newer tracers?
Yes.
Oh, that's a long conversation when we probably need a break right now. Very, very difficult.
Yeah, because I
Very,
think
very
like they
difficult.
look great, but I think that unfortunately for like sort of use in sort of most practice, I think it takes a long
They're
time, correct?
difficult. The trials are not necessarily so hard. The regulatory governance over them is not always so clear. And so there are some, that's probably the biggest impediment, I think, to getting new imaging technologies adopted.
Yeah, very different than Germany, I might add,
Yes.
where, you know, they do remarkable scans and everybody who has a little radioactive box in their office can do it.
Yep.
Yeah,
And so we
incredible.
actually did our initial studies in Germany. So the first studies we did in man were all done in Germany for that reason.
Yeah, no, it's, the Germans have got a different system.
So a biologically interesting point is that oftentimes men that have metastatic prostate cancer will have relatively small lesions when they're first starting, is individual size. Okay, they may have many of them.
Right.
And then you have the volume in the prostate. And so now you do androgen ablation. And I've always wondered about the numbers game. And theoretically, if it was just adaptation and all that kind of stuff, you would think that the biggest lesion, single lesion, would be the primary. And so you'd end up with usually the first site of relapse would be primary. But I remember when I was a little baby working in this field, senior urologists were telling me that they almost always saw the disease progress after hormonal therapy in the Mets, not locally. So my question is, have you ever imaged somebody where you've imaged them so that you know the size of the primaries and they've got Mets, so you're not going to do a radical on them, but then given them hormonal therapy to see kind of what the kinetics of the response, local versus net?
So we've done it. I don't know really the results. We're trying to do it as part of a neoadjuvant study where patients are getting, in this case, they're getting enzyme degarelix and then having surgery ultimately. And we have it written into the protocol to do MRIs at the time of diagnosis. That's a requirement. And then right before their surgery. It's been a little bit difficult to get it covered. And so we've done a few, but I don't know the results. So I don't know.
One last little follow-up to that.
Yeah.
So I was really impressed when you're showing the difference being able to detect something and actually to getting its physical volume. So the question is, is that also extrapolatable into Mets, or is that more of a local phenomenon where you're looking at the in prostate because of the different planes of connective tissue
Yeah,
and
for
things?
Mets, I don't know the answer. I mean, we have not done MR much for Mets other than bone Mets to confirm something suspicious. Whereas, in England, they've done a lot of work doing diffusion weighted imaging for bony disease. But there, I think generally speaking, metastases are quite small, so you probably don't have that issue. But I doubt there's no way to sample that, so you wouldn't know.
Well, I just think as a drug developer, what I've always been worried about is, you've got 7 or 8, 10 Mets, okay? Let's even call Sentinel-like Mets. And you give a therapy, it's a new therapy, and 5 of them responded beautifully. And 2 of them, didn't or even got, bigger. And you'd throw the baby out with the bathwater. It, quote, didn't work. And you realize, no, that's not true. It worked, but we need to figure out how to go after the other 2 that is resistant.
I think that's why I'm a big proponent of molecular imaging in the context of clinical trials,
Right.
as companion biomarkers essentially, because we don't have that and we don't know the answer to that.